Hello, everyone, and welcome to the Susan LoPresti Wellness, Mind, Body, and Soul podcast, where we empower women to reclaim their health, increase their energy, and live vibrant, fulfilling lives at every age. Today's episode is one that so many women will relate to because we're talking about the real life challenges of midlife health, hormones, and taking control of your wellness journey. I'm honored to welcome Sharon Lemoine, an advanced registered nurse practitioner and the owner of Gig Harbor Concierge Medicine. Sharon brings more than 30 years of healthcare experience, including over 25 years working in emergency medicine. Throughout her career, she developed a passion for helping women move beyond symptom management and uncovering the true root causes of their health concerns. What makes Sharon's work especially meaningful is that she doesn't just teach this, she's lived it. She's a type 1 diabetic, a thyroid cancer survivor, and has personally navigated surgical menopause and the difficult decision to undergo a prophylactic mastectomy. Those experiences have given her a very unique level of compassion, understanding, and insight into what so many women face during midlife. Today, Sharon is dedicated to educating women through her concierge medical practice, her YouTube channel, Hormones, Health, and Faith, and a thriving online community of more than 7,000 menopausal women. She believes women deserve honest conversations, evidence-based information, and a personalized care that addresses the whole person, not just a list of symptoms. In today's conversation, we'll explore hormones, menopause, root cause medicine, and practical strategies to help women feel informed, empowered, and confident as they navigate this important stage of life. So grab a cup of tea, settle in, and join me in welcoming Sharon Lemoine to the podcast. Sharon, thank you so much. Welcome to the podcast. I'm so excited to have this conversation with you today.
Thank you so much for having me. I love connecting with our community, so very excited.
Great. That's great. I appreciate it. So, Sharon, you spent more than 30 years in the healthcare industry, including over 25 of those years in emergency medicine. How has that experience shaped the way that you care for your patients today?
It has really given me a lot of perspective. I have learned a lot of lessons along the way in 25 years in emergency medicine. And really, I truly loved the work I did. I had a passion for emergency medicine, really helping people in that moment when they're having a crisis with their health. And it was very rewarding for a very long time. But I really felt I wanted to shift my career and my focus on spending time with the patient, being able to really hear them and give them the care they deserve. And as we all know, corporate healthcare has its challenges.
Yes.
And so I was given the opportunity to branch out and open up my own medical practice. And having that emergency medicine experience really has given me the medical knowledge, first and foremost. And I've really built on that to where my practice now really just takes the time to be able to validate women, their concerns. Of course, we see men as well, but really the focus is on these middle-aged women coming in health crisis and really not knowing how to navigate their health. So we are now in a practice where we can take the time and have that specialty and education to really focus on overall health, wellness, menopause, hormone replacement, and optimize their health so they're really looking at 20, 30 years down the road on where their health will be.
Yeah, that's very important. That's very important. So I know that you had several of your own major health challenges. I know you're a type 1 diabetic.
Correct.
You survived thyroid cancer and also surgical menopause, and that changed your perspective as both a practitioner and a patient. How has that changed your perspective?
Yeah, as a type 1 diabetic, I was diagnosed out of the blue at the age of 31. So a little out of the norm. It's typically more seen in juvenile onset. However, over the years, that has evolved as far as a diagnosis. And initially, I was really upset. I have always been very health conscious, always taking care of my body, even from a young age. And so when I got that diagnosis, I was really feeling a little defeated. And 25, 26 years later, I know God had a plan for one. It has really made me appreciate my health. It has certainly made me be more relatable to my patients in similar situations and has allowed me to really take my education and my experiences and really relate to my patients on a much more personal level. With the thyroid cancer and surgical menopause, all of those things, those are tough things to go through. Fortunately, I had that medical background and the base knowledge to help me navigate that, but it doesn't take the emotion out of it, right? And so again, I choose to look at those things as a blessing because it really has broadened my perspective on dealing with these issues. And so when I have these similar conversations with patients, I can certainly talk from a personal experience. And I think it allows us to connect on a whole nother level.
Yeah. Now, do you think that your experience with type 1 diabetes and also your cancer, did those diagnoses have you move to thinking about what was the root cause of this?
Yeah, of course. As we know in type 1 diabetes, that's what makes the diagnosis a little tough to rationalize because it is idiopathic. We don't know exactly what causes type 1 diabetes. So it's not like I could sit here and say, oh, I can correct one, two, or three of these particular things in my lifestyle and reverse it. This is something you can't reverse. The same thing with the thyroid cancer. I was diagnosed with the overactive or thyroid, which is known as Graves' disease. And with
Yeah.
the workup, they found a nodule, which was cancerous. And dealing with those, of course, I'm looking at root causes. And it's interesting because at the time of my diagnosis, I was thinking more corporate healthcare. I wasn't, of course, I was looking for the causes, but now in my practice, I am really focused on root cause. Let's get right to the issue. And I can understand it a little bit better. But these are autoimmune issues. As my education continues to grow and really seeing the ties to gut health and autoimmune disease, I've really gone down that path and continue to learn. That is a whole specialty in itself,
Yeah.
but can certainly appreciate looking at the root causes. Sometimes we find them, sometimes we don't have those answers, but that really has become the focus of our practice again, is to fix the root cause instead of just throwing medicine at everything.
Yeah. Do you feel that, especially with the thyroid, because I know it's connected to your voice, and do you feel that there was some kind of emotional or energetic component to you developing that? Because I have a thyroid condition as well,
Yeah.
underactive. And there was a time in my life where I was going through a situation where I was holding back my feelings and I wasn't expressing myself. And I feel like it manifested into a physical disease because I wasn't addressing the issues emotionally. Do you see a connection between physical and emotional or energetically?
I do. I think we all have that capability to make that connection. I think that as far as voice changes with my thyroid, I'm very energetic and very outspoken. And so my husband was even making a joke, maybe she'll be a little more quiet. And we laugh at that. But I didn't find too much emotional response in, I think, the physical expectation. It was more of feeling in control of my health.
Yeah.
And when you're working so hard to stay healthy, and then these diagnoses keep coming at you, you're like, what in the world is going on? It's easier if you can very easily pinpoint your lifestyle or your emotional approach to it, right? And say,
Yes.
okay, I could see where I could make some improvements. What's really frustrating is when you're already putting in the work and then these diagnoses keep coming at you. So that can
Yes.
certainly wear you down a little bit. Again, I use my faith as really rationalizing that I've got to put my head down. I've got to take care of the issue. I've got to work a little bit harder to stay healthy and realizing that there is a reason for this.
Yes, for sure. So let's switch gears for a minute. Let's talk about women when they're feeling exhausted, gaining weight, losing sleep, brain fog, and they're simply told that it's part of aging. Do you feel that's really true?
I think that is a very small piece of it. Yes,
Yeah.
are we aging? Of course. I am thankful we are in a space now where we are talking more about menopause education. I really think that pendulum is swinging compared to 25 years ago and the myths in menopause care and hormone replacement. So I'm glad that I can be in this space and help educate and really validate women. When they are coming to me, they've already seen providers. And again, being told, oh, you're just getting old, you need to just deal with it. And I think there's an appreciation when they sit down with myself and our practitioners because number one, they're heard, and we are all about validating women. Everybody feels things on a different level. It
Yeah.
affects their life differently. So we have to respect that. When a woman comes in, we know our bodies, we know what's right. A lot of times we can discount that. We put our heads down, we keep working, we've got families to take care of, but we really need to listen to that voice. And so all of those symptoms, the fatigue and the sleep issues, libido, relationship issues, it really has such a big part of our lives that I think has been missed and discounted. So when we dive into hormone issues and how much that is a piece of those symptoms, it can't be discounted anymore. And again, I think there's some great conversations happening to really acknowledge them and really start offering valid treatments for patients so they can continue living healthy and not being weighed down with these symptoms.
Yeah. What do you think are some of the earliest signs that a woman is going into perimenopause?
There's a whole array, and
Yeah.
everybody is so different. But I can tell you, commonly, I am seeing patients in my office, even in late 20s, but mostly more commonly
Wow.
mid 30s to later 30s. Women are coming in where they can't explain their low energy. They're starting to have that sleep disturbance, a little bit of weight gain. Quite often, it's that zest for life that they come in anxious or think that they're depressed. And of course, we talk about that. And more times than not, it is a physical hormone disruption versus a true anxiety disorder or a mental health issue. And when we
Mhm.
make those ties and optimize their hormones and they realize they can come off those antidepressants. And this is early perimenopause. This is the first stage I'm seeing is they come in fatigued, anxiety, and their providers have put them on an antidepressant. And when we really dive into more comprehensive blood work, I can see testosterone levels are low, thyroid function is not optimized, vitamin D and other vitamin deficiencies. Just by optimizing those, their energy is better, their motivation, their overall zest for life, and they're coming off these antidepressants. And that's early perimenopause. And as we know, perimenopause, those symptoms can start setting on mid 30s and last well into our late 40s, early 50s before we actually get to menopause. So, this is a critical time for women to pay attention to their symptoms and seek help from somebody that really knows how to navigate that for them.
Yeah, that's key. That's key. Which hormone imbalances do you often see most in a woman over 45?
Usually, number one, right out the gates, it's testosterone. And a lot
Okay.
of women don't realize they make testosterone and they need replacement. I have,
Yes.
and quite honestly, even as a medical provider in emergency medicine, this was not my specialty. So, as I've learned over the years, that was quite surprising to me as well. So the first one we talk about is testosterone. We know at 30, right around the age 30, we start to decline about 1 to 4% each year. And there are a set of symptoms just for testosterone deficiency.
Like
Even if
what?
those, so mental health, huge correlation. So the irritability, anxiety, depression. Interestingly, there was a recent study by Cambridge University, and they looked at over 950 women in menopause. So this is a little bit further down the road. They scored their irritability, anxiety, depression, as well as suicidal ideation. Then these were women that had not been optimized with hormones. They then looked at their hormone levels and gave them different combinations of estrogen, progesterone, and testosterone. Then came back and rescored their mental health. Shockingly, their anxiety, irritability, depression scores improved by 46%, and that suicidal ideation improved by 92%. And what I have seen, and I love that study because it's been what I've been saying and what I've noticed in my practice is the correlation with mental health and low testosterone levels. Now, estrogen, progesterone absolutely is a piece of that. But we're talking those women first coming through my doors, just really getting into the thick of perimenopause. So, mental health, huge piece. With low testosterone, we also see sleep disturbance, that weight gain because we're losing muscle mass. Over the years, that's a slow progression of loss. And so, with less muscle, lower metabolism, more insulin resistance. So that is a common symptom of low testosterone is that weight gain. So, and then of course the low libido, and then our sexual health and our relationships are suffering. So that is the first step that we're looking at in our perimenopausal women. Those ovaries might still be working and spitting out some estrogen, and they can go rogue on us during perimenopause. They're going to work for a few months and then they go dormant and then they're going to wake up again. So it's always a little bit of guessing game with estrogen replacement during perimenopause. We do it, but it's nice and slow and steady to support your own production until it runs out. And that is what we know perimenopause to be. And then, of course, there's progesterone that we could certainly look at in our perimenopausal women, mid 40s. Progesterone is known to help us sleep, and
Yes.
it's a calming hormone, and it can balance out estrogen nicely. So there's a whole array of combinations of hormone replacement. That's what makes it so interesting because each person can present so differently.
Yeah. I know back in probably the 70s, there was synthetic hormones and people were developing cancer. Do you find that any of your patients are apprehensive about taking hormone therapy because of back then what it was all about? I've been on hormones for years already, and it saved my life and it works really well for me. But do you get any pushback from some of your patients where they're a little apprehensive?
Absolutely. And that is really the education piece that we are
Yes.
trying very hard to do for our community. So that goes back to the Women's Health Initiative, which was one of the biggest research projects done on women. It actually started in the mid 90s. Prior to that, yes, you are correct. They were prescribing Prempro, Premarin, which
Yes.
was synthetic estrogen, progestin, which is synthetic progesterone. And so in the mid 90s, they decided to do a study. And the researchers had many hypotheses, but they were really focusing on menopausal women and the cardiovascular effects of being on these synthetic hormones. What they found over the years, this study was going on, and we have to remember the group they were studying, the average age was roughly 65. These women had various health histories already, and then they were put on synthetic estrogen and progesterone. And so what they thought they saw, and this was, I believe, in 2002, what they thought they were seeing in the research was a small uptick or small occurrence or increased occurrence of breast cancer and strokes. So they called a press conference and they said, this is what's happening. We're going to stop the study. Hormones are causing breast cancer and strokes, and made that statement. And that was what we know now as a huge misinterpretation of data. Some people have said that was the most tragic mistake in medicine for women. When they went back decades later, and we're 25 plus years after that, they have realized there was no statistical data that caused unnecessary fear. And we have tried to rewind over the last couple of decades to get the correct message out there. What's interesting is, if you go back and look at that study, there were arms of the study that were looking at women on bioidentical estrogen, meaning bioidentical matches the same chemical structure in your body, and found that it was actually protective, less incidence of breast cancer. So unfortunately, that study alone gave the misconception that estrogen causes breast cancer.
Yeah.
And if we rationally think about this, when do we have the most amount of estrogen in our body? When we're young, 20s and 30s. So why is the incidence of breast cancer not skyrocketing in that age group? What they have found now over the last few decades, as research has continued, is there is evidence that estrogen, testosterone, progesterone optimization is actually protective. Now, we don't want to mistake the fact that there is breast cancer that is receptive to estrogen, right? So we have to decipher. It's not the estrogen causing the cancer. However, if you get breast cancer and you have estrogen floating around, it certainly can feed those cancer cells, but it's not the cause.
Right.
And it's the same conversation I have with my male patients. Testosterone doesn't cause prostate cancer. Can it feed the prostate cancer? Absolutely. But again, research is showing by giving testosterone to men a little bit earlier in life, we're protecting and lessening their chances of prostate cancer down the road. So huge piece of education we are doing for our patients. And again, there's some great practitioners out there speaking, educating, and I think that correct message is getting out there.
Yeah. Is there anyone who should avoid hormone therapy?
Great question. There's always risks to everything we do, every medication, every hormone. There's always side effects. So we always have to look at each patient individually, look at their health history, look at their symptoms, look at their levels, and have that discussion and risk stratify who is the best candidate. Now, we can also break down each hormone. Some of my women with a history of breast cancer that have had an estrogen receptive cancer, they're scared, of course, for a reoccurrence. So for some of those women, they decide they feel comfortable with moving forward with just testosterone. We're going to give some energy. We're going to help maintain muscle mass. We're going to increase their libido, more zest for life. They're off and running and doing so much better. Now, they still have a risk of not optimizing estrogen because they're losing bone, right? And we know estrogen replacement helps protect against cardiovascular disease, dementia, bone loss. So what are these breast cancer survivors doing in that case, right? They are at risk. So it is a one-on-one conversation we have to have and decide risk versus benefit. Do I give breast cancer survivors estrogen? I do. We have that conversation. We do very close surveillance and follow up looking for reoccurrence of cancers, right? When I've got my women saying, I have no quality of life, my bones and my muscles ache, I can't get out the door, they've got cardiovascular risks. That is a bigger concern for them than a reoccurrence of breast cancer. Then we start with a low dose estrogen and see how they do, and we monitor very closely.
How important is timing when beginning hormone therapy?
So I tell my patients the earlier the better, because like you said earlier, are we all aging? Yes. We're trying to slow that process down. So if I had my women come in early perimenopause and we start balancing those hormones through this whole process, we are slowing cellular death. We are slowing the aging process. We are maintaining all the systems, cardiovascular, brain cells, right? Overall health, we're trying to optimize along the way. So if we start hormone therapy earlier, the chances of having less disease, less medical issues 20, 30 years down the road, the projection is much better. So start early, start slow. You don't need a lot, just a little sprinkle just to balance along the way. And then the opposite side of that question is, am I too old for hormones? There's a recommendation to really pause if you're 10 years beyond menopause, right?
Oh,
If you,
really?
yeah. Now, that doesn't mean you can't have it. It means we need to sit down and look at the risks of starting estrogen. And diving into that a little bit, we know estrogen vasodilates. So if I've got a 60-year-old lady who is 10 years into menopause, who is obese, has high cholesterol, high blood pressure, and known cardiovascular disease, I'm going to pause before I give her estrogen until we get a full workup and maybe even correct and reverse some of those issues to lessen the risk for stroke or a cardiac event. Because if I give her estrogen, vasodilate, if she's got some plaque in those vessels, those can loosen when we vasodilate and those can break off. So that would be somebody higher risk. Now, if I have that same 6-year-old come in who is 10 years postmenopause, active, healthy weight, no history of high blood pressure, hyperlipidemia, and significantly symptomatic, maybe some early osteopenia or osteoporosis, yes, 100%. Let's get some estrogen on board and let's see how you do and try and slow that aging process down.
Did you say that estrogen is important for brain health?
Yes.
Yeah.
Yes. And so what's interesting, not only in women, we know by getting estrogen on board, 50% reduction in cardiovascular disease and dementia if you start early, right? The earlier you start, the better the percentages of avoiding these diagnoses. Also interesting, in men have estrogen, they convert some of their testosterone to estrogen. So they are also, by optimizing their testosterone, they are also decreasing the risk of dementia by 50%. And again,
Wow.
the earlier you start, the more benefits you're going to see later in life.
Interesting.
Yeah.
Wow. How can women become better advocates for themselves when they don't feel heard by their healthcare providers? Because I know when I started in
Yeah.
perimenopause, and I went to a doctor, and he was a male. He says, it's perfectly normal for a woman of your age to feel this way. And I had everything wrong with me. And I kept saying, yeah, but I didn't see my mom struggle the way I am. Some doctors, they just dismiss it, really. Like you were saying, put them on antidepressants,
Yeah.
thinking that's the answer. So, how could we advocate for ourselves?
Number one, listen to that voice in your head.
Yeah.
Women are in tune with their bodies, and you know when something's off. If you go to a provider and you're asking for an extensive blood panel to include hormone levels, and they say no, then you know that's not your provider. Now, to have their backs, all providers want to do well by our patients, but not all providers are specialized in hormone therapy. So we all have the best intentions, but they just might not be equipped, or that might not be their specialty, and that's okay. I personally have been educated on hormones through BioT, which is a well known for their hormone optimization education and their products that they offer to providers and patients. So I always tell my patients, go Google a BioT provider in your area. You know they have had top-notch education on this specialty. find a doctor who's been trained, who will validate how you feel. And at least start with running the right labs and the blood work. That's your first thing, right?
Mhm.
Then you can sit down and have the conversation and look layer by layer. Because quite honestly, we can say, yes, hormones are a big piece of the puzzle, but there are other things we need to be looking at: thyroid, vitamin deficiencies, right? And all the risk factors in optimizing each one. So many layers to these symptoms we commonly come in with, and we want to make sure we're not missing the obvious. So
Yeah.
you have to have a provider that is well trained, who will take the time to listen to you, and that's going to be your best start.
Yeah. Why is thyroid function so important during midlife?
I think we all underestimate our thyroid, and it's the ringleader for so many metabolic processes and hormone balance. So when you come in and you say, "Hey, I'm irritable," or "I'm depressed," or "I just can't get out of bed in the morning, severe fatigue, can't lose weight," is that a hormone issue, or do you have an underfunctioning thyroid? Right? And I think the thyroid could be a whole podcast in itself. How many women have gone to their providers and said, "I think I've got an underfunctioning thyroid," and they do blood work and they come back and say, "Nope, your numbers are normal, go home."
Yes.
Number one, we've not addressed your symptoms. And what they should be looking at on a thyroid panel is your free T3. That's the active thyroid hormone ready to be used. If you're not converting well, then your thyroid function might be okay, but you just might need that little extra active thyroid hormone to feel good. And it's so different from one patient to another, right?
Yes.
And so that is something we don't want to miss metabolically, right? It ties to our gut health, Hashimoto's, autoimmune. Is that coming from our gut? Do we need to fix the gut to fix the thyroid? So it's a huge piece of our overall health. And so when we're talking hormones, that definitely needs to be part of the conversation.
Yeah. Now, do you think if you do fix your gut, that it would improve your thyroid?
Depending on what's going on with your thyroid. Hashimoto's, what you will see on your blood work is elevated thyroid antibodies. So
Yes.
that's basically your body saying, "Hey, I'm feeling the stress, and I'm going to attack my own thyroid." So with leaky gut, those toxins are leaking out of our intestinal walls, and one of the most common places those toxins go is our thyroid. So yes, we can reverse Hashimoto's. It's not easy. The gut has trillions of bacteria, and the microbiome is a whole specialty in itself, is balancing that out. So it takes time. It could be a gluten, a dairy, or some kind of trigger that's causing inflammation. So there's testing, there's stool mapping, and lots of supplementation that we have to look at to fix the gut. And we have seen the antibodies in Hashimoto's improve, and patients coming off of their thyroid medications. And I've seen it in my practice. And a lot of times I've seen it just by patients taking gluten out of their diets.
Yeah. That made a big difference for myself.
Yeah.
It really did. So, beyond the TSH test, what should women ask their doctors to evaluate?
So again, when you're going in and you're asking for a full metabolic workup, ask for a TSH, obviously, but you got to remember that's not looking at thyroid. That's looking as your brain telling your thyroid what to do.
Yeah.
Really know what is the thyroid actually doing. So T4, T3, and a TPO, those are your antibodies. With those three things, we should be able to see a little bit more in depth of what's happening with your thyroid function.
Yeah. What about for women, even those without diabetes? How should they be paying attention to glucose?
So in our practice, we work with a lot of patients with trying to lose weight. We do use GLP-1s, and we have them on a very strict regimen to make sure we're doing this properly. So to answer your question, is a conversation I have with every single patient. Insulin resistance is rampant in our country. And so what we have to focus on is obviously diet. It's going to come down to diet and exercise, but we can
Right.
break it down a little bit further. Diet, obviously, you need to be watching your carbohydrates and obviously sugar intake. If you think about your body taking an overload of carbohydrates and glucose all the time, it's having to spit out more and more insulin to counteract that, right? Over time, your body's going to peter out and it's going to become insulin resistant because it's, man, I just cannot make more insulin, and it stops responding. Part of that is the amount of glucose and carbohydrates we're putting in our body. The other big piece relates to muscle mass and density. More muscle density, less insulin resistance, and better glucose control. I'm from the era of cardio. When we do workout, just do a bunch of cardio. And we have quickly realized it is much bigger than that. We have to wake up the muscles in our body. You don't have to be a bodybuilder,
Right.
but we've got to get the muscle on our body to be dense and working for us to manage glucose levels. So we have this conversation with every single patient. You have to know how many pounds on your body is lean muscle mass, which drives how much protein you need in a day to maintain that muscle. If you maintain your muscle mass, whether you're using a GLP-1, whether you're trying to maintain your weight, it's about maintaining glucose levels and taking that insulin burden off your body, and so that you don't have to make as much, and we're reducing insulin resistance. So less glucose, carbohydrates, and wake up those muscles, pick up some weights, and you should have better overall glucose control.
Does blood sugar swings affect hormones, energy, inflammation, and weight?
All of it.
All of it. Yeah,
All of
that's
it,
what
yeah.
I thought.
And I can speak from on a personal level. As a type 1 diabetic, I have a continuous glucose monitor that works with my insulin pump. So I have seen this in real time, which again has been such an eye opener for myself and my own health, but I can share this with my patients. We eat something with glucose, just or a carbohydrate by itself, right?
Yeah.
And we're going to see in real time a spike in our blood sugar. So it comes up and then it comes down. And when that's happening, you feel that quick little spurt of energy and then you crash.
Yeah.
And when you do that all the time, the peaks and the valleys, absolutely, you're trying to regulate that glucose level, the insulin demands, your thyroid metabolism, trying to adjust for that. It can certainly wear out the systems. So we're trying to stay here versus the huge peaks and valleys. And there's a lot of education that needs to go behind that as far as what we're putting in our bodies, what's keeping those fluctuations from being so drastic, and staying closer to that homeostasis to not have the big hormone fluctuations over time.
Yeah. I personally think that most people should wear the glucose monitor because we don't realize what's happening when we eat a pint of ice cream or
Yeah.
something. It's so delicious, and you're in front of the TV and you're just spooning it. But if you knew what was happening to your body based on a glucose monitor, it may spark something and someone say, gee, I should not be doing this because it's really not too good. I think they're great. I really do.
Yeah. In our weight loss program, every patient gets hooked up with a glucose monitor. It's called Stelo, Stelo. You can look it up. But every patient gets hooked up with one of these for the first 2 weeks. And what I tell them is the first week on our program, they're trying to make some corrections, but we try to ease them into diet and exercise. So I tell them the first week, just cruise like you normally would be eating or what you think is healthy, and they will see the spikes in their blood sugar. Then the following week, I said, okay, then you really want to clean up that diet and make some corrections. And when they see the difference of that first week and that Starbucks that they really love with the sugar in it, or maybe that healthy protein bar they didn't realize had so much carbohydrate in it, they see these huge spikes and they're like, oh my gosh, I thought this was a better choice. Very eye-opening. And then allows them to visualize now when they're eating exactly what's happening to those glucose, those levels.
Yeah, I think that's important because you're aware. You
Yeah.
know, if you have nothing to base it on and you're just eating and that was delicious, you're not thinking about what it's doing to your body. But to see it in black and white, it makes you aware.
Yeah.
I think it's really
Great piece of
important.
education for our patients.
Yes. Yes.
Absolutely.
I just want to talk about surgical menopause.
Yeah.
What exactly is that, and how is it different from natural menopause?
So surgical menopause, we can define it a couple ways. There's a partial hysterectomy where they just take the uterus. There's a complete hysterectomy where they're taking the ovaries and the fallopian tubes. So if women going through their 30s and 40s decide to have a partial hysterectomy, uterus is coming out, they still have those ovaries. So those ovaries are still making estrogen. So a little bit less impact on hormone levels versus surgical menopause, they're taking everything and boom, overnight, you're making no more estrogen. Now, for me, I chose to have a complete hysterectomy based on I have a high family history of breast cancer. And so I didn't want to, I thought if they're doing surgery, just take it all. Less risks for ovarian cancer down the road with my family history. The
Uh-huh.
other thing is with my blood sugars, I found with the fluctuations in estrogen, it was really affecting my blood sugar. So I was just trying to really control that more steadily. And I thought by taking the ovaries out, now this was before I was a hormone specialist, that I made this decision. My thought was maybe I'll have better glucose control without second guessing what my ovaries are going to do. I had my surgery and I went 5 years without any hormones. And so I was about 45 when I had my hysterectomy. And quite honestly, the first couple of years, I think I felt okay. We always adapt and think we were okay.
Yeah.
And then 3, 4, 5 years into it, I couldn't sleep, very irritable, anxious, brain fog. And that was about the same time that I was shifting my career into hormone optimization. So, of course, I was having this aha moment like, wait a minute, I need to get these hormones on board, not only to make myself feel better now, but the risks I had for osteoporosis, cardiovascular disease, and dementia. I was like, let's slow this down big time. So, it was a learning curve. And again, I'm glad to have that experience because I know what not to do with my patients. And I can certainly speak to what it feels like to have no functioning ovaries.
So, is that an elective surgery, or did it have to be done because there was something physically going on with you? I never really heard of surgical menopause before.
Yeah, commonly, especially with my background in emergency medicine, that classic patient would be the female in her mid 40s coming in because for severe fatigue. And come to find out, she was having heavy menstrual cycles more often and turned out to be severely anemic. And some of these women were actually needing blood transfusions because they were so depleted. So, looking at the root cause, they needed a hysterectomy because they just couldn't live needing blood transfusions every other.
Yeah, gotcha.
So often women, either they have uterine fibroids, sometimes it's endometriosis, but more times than not, it's the anemia that is one more commonly a reason to discuss having a partial hysterectomy. And I've seen patients in my office as well where they come in, I'm like, oh my goodness, your ferritin levels, you're severely anemic. We start talking, we realize this is because of heavy menstrual cycles. I refer them to OBGYN. They come back 6 months later and say, oh my gosh, I feel like a rock star because I had my uterus removed. And so they're doing so much better, right? When you decide to have your ovaries, now that could be an elective or a discussion to have with your physician is, do you want to, if you're having surgery for that scenario, do you want to keep your ovaries? It's very individual, right? Again, if you've got functioning ovaries that are still making estrogen, you might want to hang on to those as long as you can. We can supplement along the way.
Yeah.
if you have a high risk for ovarian cancer in your family, or if you've got severe endometriosis or whatever that other cause may be, those are things to consider if you're having a hysterectomy, whether to keep your ovaries or not. But just knowing that you're cutting the energy, you're cutting the hormone levels off immediately when you take those ovaries.
Yeah. Sharon, any final thoughts you'd like to leave my listeners with today?
Number one, thank you again for having me. I just have a passion for educating women, validating, and really showing them how to get the proper care. Our practice is faith-based, so it's always looking at God to really give us the motivation to take care of this awesome gift He's given us. And I'm here again just to educate and motivate women to just be their best and really empower them to take control over their health.
Yeah. Do you see patients virtually?
I don't. I can in the state of Washington. So
Oh,
once you've established care with me, we certainly do telehealth medicine, but based on restrictions and licensures, I can treat in the state of Washington, and that's where I'm residing currently.
okay, gotcha. Sharon, thank you so much for being here today. This was such an important conversation for my audience to hear. And I love the work that you're doing, and I see you're very passionate about it. And I wish you the best of luck.
Thank you so much.
It was my pleasure. As we wrap up today's conversation, I hope that you're walking away feeling informed, encouraged, and empowered. Sharon reminded us that many of the symptoms women experience during midlife aren't simply something that we have to accept as part of aging. By understanding our hormones, asking the right questions, and getting to the root cause of our health concerns, we can take meaningful steps towards feeling our best. Sharon, thank you so much for sharing your expertise, your personal journey, and your heart with us today. Your passion for educating and empowering women is truly inspiring. And I know our listeners have learned so much from this conversation. And to all of you listening, thank you for spending part of your day with us. If you enjoyed this episode, please take a moment to subscribe, leave a review, and share it with a friend, a sister, or someone who could benefit from this information. Your support helps us to reach more women who are looking for hope, healing, and practical tools to live healthier and more vibrant lives. Be sure to visit the show notes for links to Sharon's work, including her concierge medical practice, her YouTube channel, Hormones, Health, and Faith, and her social media community, where she continues to educate and support thousands of women navigating midlife and menopause. Remember, your body has an incredible capacity to heal when given the right support. It's never too late to prioritize your health, nourish your mind, strengthen your body, and care for your soul. Until the next time, this is Susan LoPresti wishing you abundant health, lasting vitality, and a life that's filled with peace, purpose, and joy. Take care. I'll see you in the next episode of Susan LoPresti Wellness, Mind, Body, and Soul.